So my name is Tanya Paler, and I'm Director of Marketing and Communications at MedStar Montgomery Medical Center. And it is my pleasure to welcome you to our 5th annual Girl Talk with the Docs event. And I see, yay! I definitely see some people who were here last year, and there's lots of new faces, and so we're excited to have you as well. This event is a really fun event. It's an intimate evening designed for you to be able to ask any type of question that you want to ask to the doctors. I do have the pleasure of introducing our guest moderator, who is returning for a 3rd year, NBC News correspondent Tracy Potts. You may recognize her as the face of Washington News every morning for more than 150 NBC stations, as well as the Early Today Show. In addition to covering the news from Capitol Hill each morning, Tracy is actively involved in the local community as a board member of the Montgomery County PTA, with her children's schools, and with her church. And returning for a 2nd year, we are partnering with the local women's organization, Top Ladies of Distinction Incorporated, the Patuxent River chapter. And so we're very happy to have them return again to partner. And at this time, I'd like to introduce the president of the organization, Mrs. Wanda King.
Well, good evening, everyone. It is wonderful to see so many of you here, and like we call ourselves ladies. So like Lady Tanya said, this is our 2nd year partnering with MedStar on this wonderful event. So we're excited about what the doctors have to share, and each time we learn something from each other. And I think this is a wonderful setting for you to get that question answered that you've had in the back of your mind, and you thought, gee, I wonder, but I was afraid. This is where you can ask that question. The Top Ladies of Distinction Incorporated is an organization founded 55 years ago, 1964, in Tyler, Texas. And we exist as a humanitarian organization to help. We basically serve youth and adults. That's our mission. We have a number of program thrusts and projects, and one in particular is our service for Status for Women. And this particular program and partnership comes under our fantastic Status of Women chairman, just happens to be Lady Tanya Paler. And then we also have our signature program, which is our Top Teens of America. So I am really thrilled to see that some of our young folks are here. So our top teens, I know I saw one. If you will please stand so that we may recognize you. And please give her a big hand. She is the, I believe, first vice president of the Patuxent River chapter of Top Teens of America. And then we also have a number of the ladies here. So if you're a member of the Patuxent River chapter of Top Ladies of Distinction, please stand so that they can see who you are. So again, we are truly honored to be here, and we thank you and MedStar, and we're looking for a fantastic evening. So thank you all. Have a great time. Bye-bye.
Thank you, Wanda. Okay, so we're going to turn our program over to the moderator at this time. Now, there should be index cards on each of your tables for questions, so be sure to take time to fill out those questions, and then we'll be coming around throughout the evening to pick those up so that we can hand them off to our moderator. All right, Tracy, you can take it from here.
To be back here for the 3rd year, and I'm noticing that every year we're getting a larger and a more diverse group of women, which is wonderful because as a reporter, you know, my job is to tell you and share information. I spent many years as a health reporter, so this is really sort of up my alley. I work on a board right now that encourages health journalism, so I spend quite a bit of my time trying to get information out there. But what we're actually finding is, as reporters, is engagement, what we like to call community engagement journalism, is the way that people really learn. And the bottom line is that's what we're doing tonight. We're engaging you by bringing the doctors to you. It's Girls Talk with the Docs. You're the girls, they're the docs. So really giving you an opportunity as opposed to filtering information through me, which is great, and it works on a large scale, but these types of opportunities where you can come and ask your questions, and as Tanya said, nothing is off limits, and I can tell you from the last few years, nothing is off limits. We have some good questions in here. That's what the index cards are for on your table. So we really want you to feel open to ask those questions that you've been thinking about that relate to your health. So I now have the honor of introducing our doctors for the evening. We will start to my right with Dr. Ngozi Wexler. Dr. Wexler is the head of the Montgomery Obstetrics and Gynecology program. Here, she specializes in female sexual dysfunction and using minimally invasive gynecological surgery to treat uterine fibroids and other female conditions, something a lot of women suffer with and also get resolution from once they receive treatment. She also treats patients experiencing infertility and high-risk pregnancies. Is Dr. Sher. Dr. Sher is a board-certified plastic surgeon. She is new to Montgomery MedStar Medical Center, offering a wide spectrum of plastic and reconstructive procedures with a special interest in breast reconstructive surgery. She also takes great interest in all areas of plastic and reconstructive surgery, including cosmetic surgery. So whatever it was you were thinking about getting nipped and tucked, she's going to answer those questions for you. And Dr. Ryan Macdonell. So Dr. Macdonell is a fellowship-trained total joint surgeon. He's the chief of the total joint service at MedStar Medical Center. He's part of the MedStar Orthopedic Institute. He has specialized training in minimally invasive total hip, knee, and partial knee replacement, including direct anterior total hip replacement, one of your special interests, rapid recovery surgery. And Dr. Dawn Leonard, who I understand is site director for the breast health program at MedStar Montgomery. So I know you're going to have a lot of questions for Dr. Leonard when she's here. A native of Olney, she completed her fellowship in breast surgery at MedStar Washington Hospital Center, sister hospital in Washington, and brings with her a wealth of experience building NABPC accredited breast centers. Dr. Leonard oversees the development of the new outpatient breast center, which I just learned is opening later this year. Dr. Wexler.
Hello, everybody. Thanks for inviting me. It's nice to see everybody. And the last time I was here, we had just more older generation, and now I see everybody from, I'm sure there's someone who's in their 20s, 30s, 40s, 50s, 60s, 70s, maybe 80s. So it's really nice to see everybody here. So thank you for choosing to take your time to come. It's such a beautiful day outside, and thanks for sharing it with us today. Hope you can learn a thing or two from all of us. So like she said, I'm the chair of OBGYN at MedStar Montgomery. I've been there for the last 2 years. And while I do have a special interest in female sexual dysfunction and minimally invasive surgery, I also take care of pregnant patients. So I'm hoping that today I'll give you some information about from when you want to start your family to when you want to take care of your family, and eventually to focus selfishly on yourself. So hopefully I can answer those questions. What's new in the OBGYN world? I'll talk about OB and I'll talk about GYN. So for OB in our department, we're hoping to start a new innovative way of seeing our obstetric patients. It's our hope that sometime next year we'll start a program called OB Centering, where the idea is that we think that it's not just your doctor who can teach you, it's your fellow patient, fellow friend. So we'll start having patients who will have group OB/GYN appointments where we can learn. OB is not rocket science. We've been doing this for thousands of years. And to be able to learn about how different patients take care of the same issues that you may have is a different way of handling obstetric complaints. So we'll have basically like sister groups of patients who have the same due date and will come for a group appointment. It will be like a 2 to 3 hour appointment. Instead of coming in, I measure your uterus and I check the baby's heartbeat. How's everything going? Oh, great. Okay, well, I'll see you in a couple weeks. You get to actually talk with a lot of women and talk about different things that could be bothering you that you may not be able to want to speak up about, such as interpersonal violence in the home, depression, things that are very sensitive that you may not feel comfortable sharing even with your doctor, but maybe you hear someone say something and it encourages you to speak up. So that's what's on the pike hopefully next year. On the GYN side, we continue to try to find new and innovative ways of taking care of our patients. So certainly at MedStar Montgomery, we already do robotic surgery, but we're thinking about getting the new SI robot hopefully in the next year or two. Hopefully we'll get that here. And it's just an innovative, faster, easier way of doing surgery, sending patients home same day, within a couple hours after major surgery. So I'm looking forward to answering all the questions. I'm sure there's going to be lots. And that's all I have.
All right. I'm Sher. Thank you again to Tanya and for Tracy for monitoring. I'm excited to be here. I'm a new member of the MedStar Montgomery General family. I've been at Georgetown full-time, and I'm happy to be up here as of February. My primary focus is breast reconstruction. I work very closely with Dr. Leonard. And our goal is to keep, if heaven forbid you are diagnosed with breast cancer, or there's any concerns, we can keep your care closer to home. So you're not having to drive into DC. For breast reconstruction, we're able to offer almost everything at Montgomery General, which is wonderful. We are doing different things with enhanced recovery, so you have less pain post-operatively. We're even doing some mastectomies and reconstruction where people can go home the same day because everyone does a little bit better at home. So that's sort of our ultimate goal. I do a little bit of skin cancer reconstruction, a lot of breast reductions. I work with Dr. Brebbia and his team for post-bariatric weight loss reconstruction. And then kind of the fun part, mommy makeover. So when you're ready to kind of take care of yourself, I'm also your lady. So I'm very happy to be in Olney, and I would love to help take care of all of you. So come see us.
I'm Ryan Macdonell. I'm the Chief of Total Joint Surgery at Montgomery Medical Center, or MedStar Montgomery Medical Center. And basically, I focus on mainly lower extremity hip and knee arthroplasty, revision hip and knee arthroplasty, because they sometimes do go wrong. But we see patients with all types of conditions from all age groups, whether it's, tweaking your knee, playing soccer, or long-standing arthritis or other conditions. And, obviously I have partners, hand specialists and sports medicine specialists, so we kind of can cover all the bases with regard to orthopedic conditions. I've been able to implement, our rapid recovery protocols in our hospital here, getting patients out the same day or the next day for most of the procedures that we are doing, and really focusing on getting people back to living their life, because that's basically the whole purpose of orthopedics, is to keep you moving. We've been able to bring our program up to speed and maintain our quality with limiting complications and infections, and really taking good care of people in our hospital. We have a nice dedicated joint unit that I oversee and make sure that we're doing everything we can to keep people safe and happy and comfortable as they recover from surgery. And so, I've been really happy with my time here for the last 3 years, and look forward to, spending my career here and really moving the program forward into to a center of excellence for total joint replacement. And I think we're well on our way.
Wonderful, thank you. What are some healthcare tips for busy moms and busy women, particularly? A lot of times we're busy. We do a lot of stuff. We're involved in this and that, and we put ourselves on the back burner. So whether it's breast health, whether it's joint pain, whether it's GYN, what are some things that you maybe wish that your patients who are busy women would focus on a little bit more? Okay.
I would say, everybody asks me, am I doing damage to my joint? The joint's hurting you, you're not hurting it, okay? So if you have aches and pains, keep moving is my number one philosophy. Obviously, if it's debilitating pain, you can't get up and around, you can't, move, get it checked out. But, the minor aches and pains, I really encourage people to, push through the discomfort, don't push through the pain. Find those 5 or 10 minutes to, work out. I mean, I have my little app with my 7-minute workout days I can't get to the gym, because we have tons of studies showing maintaining a healthy weight, maintaining that healthy blood sugar, minimizing the comorbidities that come with, obesity, really does a lot for health overall, obviously, but also joint pain and joint health. And if it ends up coming to the point where you do need surgery, helps minimize your complications and your risks. So my philosophy would be keep moving to the best of your ability.
So can I ask a quick follow-up on that before we jump on? You know, I'm a reporter, we do that.
Of course.
So when you say, well, I always figure if the question's in my mind, then it's got to be in somebody else's mind. So when you say push through the pain, but not the discomfort.
Now push through the discomfort, not the pain.
I got it backwards. See, that's why I'm asking the question. So push through the discomfort, but not the pain. So that's interesting. That wasn't quite what I would have thought or expected you to say.
Well,
does that mean that some degree of that is going to be, hi, she's here, yay. So does that mean some degree of that is to be normal and expected as we age?
As we age, it's normal for our joints and the fluid around them to not hold on to as much water as they used to, okay? And because of that, your joints can click, they can pop, they can, be, not move quite so well and not be as well lubricated. And that's okay. That's not a sign of anything bad happening. That's kind of normal aging, but, aches and pains here and there, take your Advil, take your Tylenol, that's okay. Obviously, if it's persistent, you're noticing yourself doing that all the time, obviously that's, a reason to get checked out to make sure it isn't anything more serious. And, it rarely is, but we want to know just in case. But does that answer?
Totally does,
okay.
yeah.
Okay.
Mine would be probably a few different points. Number one, take time for yourself. Like, we're all very busy. Our kids don't sleep. We are running them around. We're all working. You need to keep up with friends. So try to find 5 minutes a day for inner peace and try to take care of yourself, because self-care is very important for mental health and your overall well-being. So, and I know even 5 minutes is easier said than done. Get your annual mammogram. That will help keep you overall healthy, and and you need to go see someone every year, so that just also helps you check in, make sure blood pressure is well controlled. There's no concern from a mammogram standpoint. And then lastly, wear sunscreen, because that will help fight off premature aging, help prevent any melanoma, other skin cancers. And if you don't have a care established with a dermatologist, that's also good for just annual skin checks for everyone.
Dr. Wexler?
Yes. So I would say exercise. Spend time with your partner if you're in a relationship, and make sure that you're focusing on yourself. For the women out there who, are of childbearing age, and sometimes you focus on your career too much, and then you come to see me when you're 42 years old and you're wondering why you're not pregnant. I had a friend who turned 40 last year, and unfortunately got diagnosed with breast cancer, and she was crying, and I said, I know you want to have kids. Have you thought about ovarian preservation? Has anyone talked to you about that? And she said, what are you talking about? And I said, you should go talk to an infertility specialist about whether or not they can retrieve your ovaries and perhaps preserve them if you can afford to. And she asked me, do you tell your patients to do that? I wasn't until a year ago. And so it's something to think about. I'm not saying you should go get your eggs and freeze them, but just to know that I've told somebody to make sure that you've thought about, your career, fine, but it's better to be pregnant at 45 with a 30-year-old's eggs than with a 45-year-old's eggs. And so if one of you listens to me and thinks about that, I've done her a good service.
What I would tell you is learn how to say no. It's as simple as that. No is the most powerful word in the English language. It does not need an explanation, it does not need a defense. When you learn how to say no, you avoid doing what I did, getting overscheduled and running late everywhere that you go. As simple as that. You say no, you get more sleep. You say no, you get more time for yourself. You say no, you save money for vacations and lovely bags and beautiful jewelry. So my advice to you is learn how to say no.
Dr. Macdonell, on this one, do you recommend having both knees replaced at the same time?
That is a controversial question. Question was, would you recommend having both knees replaced at the same time? So what we know is when we look at doing one knee replacement and then another knee replacement, what we call sequentially, or a few weeks or months apart, and then kind of adding the risk of complications from them compared to doing two in one setting and seeing what the complications and outcomes from them are, that there is a slightly higher complication rate of doing both at once than doing them sequentially and adding them together. And so I will do it in very highly select patients. And there's kind of two ways of looking at it. Patients say, I can do it once, be done with it, one recovery, it'll be not much fun, but then I'll be done, versus, extending it out a little longer, doing the surgery sequentially. And so younger, healthier patients, that can really, hit the ground running with their rehab, because the recovery after a knee isn't easy, and it takes some effort, so I will, in a highly select group of patients, depending on their outlook, I'm okay doing it and will recommend doing it, but it really is a conversation to have as far as the risks and benefits, because you do want to be very careful about avoiding those complications.
Dr. Wexler, if you had a hysterectomy, do you need to have a pap smear? It's a loaded question, even though it doesn't sound like it. It depends. So if you've never had any abnormal pap smears, never had a procedure called a LEAP or conization, where you're taking out a chunk of your cervix for an abnormal pap smear, then you do not need a pap smear. If, however, you were a DES, who knows what a DES baby is? So if you were exposed, if your mother was exposed to DES and then you ended up, having a hysterectomy, we still recommend pap smears. We don't do HPV testing in such patients because the type of cancer you get has nothing to do with the HPV virus. If, however, you have had a LEAP or a cone for what we call moderate or severe dysplasia, then yes, we still want you to have pap smears for at least 20 years after the time when you had that abnormal pap smear that led us to do the code knife conization.
Dr. Sher and maybe Dr. Leonard, please weigh in. Is breast reduction surgery considered cosmetic surgery?
So the question was, is breast reduction surgery considered cosmetic surgery? In, I would say 98% of my practice, no, it's usually covered by insurance, and but that's on a case-by-case basis again. Usually women who are candidates for breast reduction are women who have chronic back and neck pain from large breast. You've tried multiple bras, you've exhausted physical therapy, massage therapy, chiropractic therapy. Women get irritation under the breast during warm weather months. You're taking Advil or Tylenol, or you've seen a chronic pain specialist for back and neck pain. In those cases, women are candidates for breast reconstruction, and then we have to submit everything to your insurance company with some pictures, and in the majority of cases, they say yes. Breast reductions can be done for cosmetic reasons, because at the end of the day, the insurance company wants us to say we're going to remove X amount of grams, and that fits into their algorithm based on a woman's height and weight. So if you need less weight taken off, however, you still feel like you have large breasts or a lot of extra skin, and your breasts are droopy after breastfeeding or with gravity, some of those cases are considered cosmetic, but I would say 98% of my practice, we do breast reductions for insurance.
Dr. Leonard, thoughts on choosing traditional mammography versus 3D mammography? And let me throw this in, is it a choice? I mean, I would think that access, availability, and all of that may come into play.
Y'all got me working out up here, getting up, getting down, getting up, getting down, getting up, getting down, getting down. So traditional mammography is actually plain film mammography, and we have moved well beyond that to what we call digital mammography, which uses the assistance of computers to manipulate the density within the breast to make diagnostics easier. A 3D mammogram is what we call tomosynthesis. It's where they take multiple views through the breast, multiple cuts through a moving mammogram. So it's pretty much the same as a traditional mammogram, or what we would consider a traditional mammogram now, which is a digital mammogram. In women who have dense breast, who are perimenopausal or premenopausal, a 3D mammogram is superior to a plain mammogram. It increases the detection rate of breast cancers in those populations by 38%. It is optional, and some insurance plans prefer not to pay for it, okay? If you have fatty breasts or breasts that are very easy to see through, then a 3D mammogram isn't really going to benefit you much. So you don't need to feel as though you need to cough up extra dough. But Medicare does pay for 3D mammography. Most insurance plans will pay for 3D mammography for diagnostic purposes, which means you're going there with a problem that is being evaluated. Most importantly, however, is get the mammogram. I'll take it. Get a 2D, get a 3D, get a mammogram. because no mammogram is no diagnosis.
While you're standing, follow-up question. Because there's been so much confusion about this in recent years, what is your recommendation on when and how often we should be getting those mammograms?
Every year, period, from age 40 on, period. Not every other year, not starting at 50, 55, 60, 65, 70, 75, 80, 85, 99, 95, okay? And those recommendations I'll slap up there in a little while as well. If you have elevated breast cancer risk, if you have a family history where members of your family were diagnosed with breast cancers at early ages, before the age of 40, then you may need to start mammograms before the age of 40, and it should be discussed with your provider. Every year, 40 on, as long as you have quality of life and feel as though you would benefit from it. So I do not give patients a cutoff point for mammograms, as long as they have quality of life.
How can you lower blood pressure naturally?
You know, doing things that kind of decrease your stress. I mean, there are people who, if you're African American, for example, you're at a higher risk of having hypertension. But certainly, lifestyle, modifications like exercise, having a healthy diet. But then doing things like yoga, Reiki, Tai Chi, things that will kind of help you de-stress. I think can all help to decrease your blood pressure. The only thing you can't change, though, is sometimes genetics are just the way they are. So.
What is the normal age for early onset menopause? Is your late 40s too early, and is there a chance your cycle could return?
Yes, so the average age for menopause is age 51. Before we consider you as a patient who has what we call premature menopause, you would have to be under age 40, which means that you could be 40, 41 years old, and once your cycle stops, if you've had 12 months of no menstrual cycle, you're officially postmenopausal. Once we diagnose you as a postmenopausal woman, if you then start having vaginal bleeding, the question arises, well, what is that coming from? Most patients who have postmenopausal bleeding have it from what we call atrophy. Everything's kind of dried up, and it can be so dry that eventually you have some spotting. But sometimes you can have heavy bleeding because you have fibroids, which don't kill you. The things that I worry about, that I'm thinking about whenever you're postmenopausal and you come to see me in the office is, do you have cancer or precancer? So, the things that we call precancer of the endometrial lining would be things like endometrial hyperplasia. Sounds like a big word, but those cells basically are normal cells, and over time you have an overgrowth, and those normal cells decide they want to be like unruly teenagers and start doing things that they're not supposed to do. And then we usually will have a endometrial biopsy or sampling inside your uterus to look for those types of abnormal cells. And if we do see them, we actually recommend a hysterectomy, or we can sometimes give you a medicine called progesterone that can help to keep those cells at bay and regulate your cycle. So if you do have cancer postmenopausally, then of course we have to take out that uterus and hope that it's not far advanced enough that we're having you do radiation or chemotherapy.
Do you have a stem cell program? How successful is that for the knee? Are there other choices besides knee replacement for bone-on-bone knee situations?
So we do not have a stem cell program at our institution now. We do what's called platelet-rich plasma, which is utilizing your own blood and some of the healing factors in your blood to help treat the arthritis. For advanced arthritis in the knee or the hip or any other joint for that matter, everybody thinks of arthritis as cartilage loss, and stem cells can rebuild cartilage. Let's inject the cells into the knee. We'll regrow cartilage. It'll be like I'm 20 years old again. Fortunately, it's not that simple. There's a whole lot of factors that cause abnormalities in the knee that we accumulate, or any joint. The cartilage wears out, the bone gets exposed, the ligaments, tighten down and constrict, the range of motion gets limited, the angle of the joint changes. You've seen some people with really bad arthritis kind of walking very bow-legged. And there's a lot of misinformation out there about stem cells. I'm not going to, say there's no potential there and that it's not certainly something that we, will include in our treatment options. It's just right now the long-term data on stem cell treatment for advanced arthritis in particular is very limited. And so you will see all sorts of claims, on, certain physicians and websites about what stem cells can accomplish. And the fact is there is not a significant amount of data to back that up. For the most part, they're safe, especially when it's preparations of your own blood, but it's very hard to track, one, what's being injected. Are the cells they harvest viable? Are the carriers they're in keeping those cells viable? And then, when you inject them into your knee, right, through a syringe, your knee is full of fluid, whether it's arthritic or not, what's to say those cells are going to go to where the cartilage is missing, magically take up space, start to grow, and regrow normal cartilage. And we don't have any studies that say they do that. And so you have to be very, very careful about what the claims are. Basically, where the data is right now is that the stem cells have been shown to improve pain for 6 to 9 months, which is comparable to things like the platelet-rich plasma, which we utilize, as well as other things like cortisone injections and what's called viscosupplementation injections, which are lubricating injections that help increase the cushioning of the fluid in your knee. And so there's promise there, and it will have a role, but for now, it does not reverse arthritis. It does not cure it, and while nobody looks forward to having their knee replaced, the knee replacement surgery has, decades and decades of long-term data showing, 85 to 95% satisfaction, significant return to function, return to activity, and elimination of pain. And so it is the gold standard, and, time will tell how those stem cells play a role in the treatment of it.
I'm actually glad that you said that. I will echo, not a physician obviously, but I had an opportunity earlier this year to do a journalist residency at the Mayo Clinic, and had dinner with and interviewed the doctor who heads their program there. And he said exactly the same thing. There's so much misinformation out there. He said that they have sort of like a phone bank where you can call in and find out, hey, is the stem cell thing for me? I mean, he said like 90% of the people they turn away.
Well, yeah, I mean, the FDA has even come out to warn these organizations, putting this information out there that they're going to crack down on what people are trying to claim they do. And I've had patients spend $12,000, $16,000 on the injections, and I don't think they were happy with the money they spent.
Yeah.
I'll put it that way.
Don't sit down,
Okay.
because because the person who got your quote right here, pushed through the discomfort, not the pain, wants to know how much Advil is too much.
So anytime, Advil has side effects, the main ones being stomach irritation, and it's processed by your kidneys. So, for acute issues, somebody strains their back, has a bad fall and their knee swells up, I'll use up to 800 milligrams 3 times a day. I don't like using that chronically, meaning long term, and so I'll tell patients to, use it judiciously. If, you're going to go play golf and, your knee or hip or something may act up, take it in the morning, take it in the evening. If it is to the point where you're finding you're taking it 4, 5, 6, 7 times a week and it's getting fairly repetitive, there are prescription anti-inflammatories that are once daily, a little easier on your stomach, and so that's kind of when I'll have those conversations with the patient about maybe switching to something that's a little easier to take.
So it's not just the amount that you're taking, but it's the frequency.
Yeah, the frequency as well as how long you're taking it. So I don't like people being on them long term, but if it's helping them avoid having to have surgery and things like that, I'll work with them on that too.
Thank you.
Mm-hmm.
There are actually some anti-inflammatories, like Motrin or naproxen, that some companies now are adding medicine to also protect your gut. They cost a lot of money. You can just do it the cheap way. Buy Zantac or something else to kind of help protect you if you have to do that. But certainly we still don't want you being on that long term.
Dr. Sher, what would you say was your most difficult reconstructive surgery, or what's the most challenging type of reconstructive surgery that you've seen?
I mean, I spend a lot of my time at Georgetown, so sometimes it's just what walks in the door. So I work quite frequently with a lot of the surgical oncologists and neurosurgeons or thoracic surgeons. So anytime you have a big tumor that's invading like the chest wall or the scalp, and you have to really reconstruct skin, soft tissue, muscle, and bone, those cases can be quite challenging. Part of my training was in microsurgery, so we'll take skin and fat or muscle or bone from one part of your body and basically transplant it. So take it with its blood supply and connect it to the blood supply in the area that needs reconstruction. So those cases are generally require a little bit more brain power and time, and they're a little bit more physically demanding because they're in the range of 5 to 10 to 12 hours, depending on how things are going. But those are usually the most, I would say, physically demanding. I think some of the most challenging cases can be the oncoplasties that we do for breast reconstruction, because if a woman comes in with size B breast and she has a tumor that's 1.5 centimeters in diameter, and the breast surgeons have to take a margin, that can be up to 25 to 30% of her breast. And then I have to make it look like her contralateral breast. So we'll either move tissue in from the side of her chest, or rearrange the breast completely, and then do a reduction on the other side so that they have symmetry. So those are definitely some of the most demanding from a plastic surgery fundamental standpoint, because you want to replace like with like. Women want to have a nice round soft breast, and I want it to look similar to the other side. So kind of twofold.
That sounds really challenging, and it made me think while you were saying that, how much, as you explained that to patients prior to surgery, how much does that weigh in on their decisions, going, oh, maybe not, but then, many times this is as you and Dr. Leonard work together, this is a medical issue that has had to be addressed.
So it definitely is a conversation that Dr. Leonard and I have quite frequently. It's number one, and I can't say this enough, it's what is the most oncologically safe decision for the woman? Short-term, long-term, what's going to get the cancer out? So what is a safe operation for her? And then beyond, cosmesis comes way behind that. It needs to be what's going to be the safe operation for you. So those are things, women have all different reasons for why they choose what operation they have, but number one is what is safe for you.
Thank you. Dr. Leonard, could you follow up on that a little bit? Because I'm thinking, as you talked about what's safe for you, when women first hear, those words, you have breast cancer, I've heard you talk about this before. It can be a scary thing, but even just over the course of time that I've reported on health, it's amazing the treatments and the advances and the options that women have. Can you speak to that a bit?
I think the most important thing is to understand that cancer treatment is individualized. There's no cookie cutter approach. And the treatment plan that's developed for any given patient has to be specific not only to their disease in the breast, but also their overall health, their age, their willingness to undergo what other additional treatments are recommended in addition to surgery, and what their goals are for treatment. And it should be a shared decision. The days where we just tell you what we're going to do and you smile and grin and bear it, that's pretty much over. It has to be a discussion and a shared decision, because in addition to curing the disease or controlling the disease or eradicating the disease, we want you to be able to put that behind you so you can go on and live a quality life. And understanding your goals is half the battle. Different people want different things. Different people have different expectations, and they have to be managed accordingly. Sometimes expectations are out of line with reality, and those are difficult discussions to have. So, the approach now is as wide and broad as you can possibly imagine, from complete eradication of the breast, and in some cases to no surgery at all, and managing it differently in the appropriate patient. So there's no one size fits all anymore. It has to be shaped and designed for you. And there has to be an understanding of what is a reasonable expectation for the end of treatment. If we don't provide reasonable expectations, nobody's happy. We're not happy, you're not happy, your families aren't happy, But I think if we have open and honest conversations about what is a reasonable expectation and what are your goals and how can we get you there, I think we get the best results all around. And there'll be a different result for every person.
You mentioned family, and I think we may have talked about this before. I can't remember if it was you or at one of our forums. How often, you're the doctor, and obviously your focus is your patient, but how often are you seeing patients really challenged, torn, divided because their goals and their family's goals are not quite the same. And how do you work through that? I mean, I'm looking at a room full of women that may be, facing some of these challenging health situations at some point. And as you said earlier, learn to say no and focus on yourself. But we don't always do that with health decisions. So what do you see and how do you see patients working through that?
So the first question is, how often do we see patients that may come with family members, loved ones, or friends who may have a different expectation and a different goal than they do? Every day. Every day. And the most important part of the discussion when that occurs is for the patient to understand that they are an autonomous individual and we will respect their choices. Your body, your choice. Okay? Sounds familiar, doesn't it? It definitely applies. My job is not to make the family member happy with the decision of treatment. It's to make the patient happy with the decision for treatment if they are an autonomous individual. If they are not autonomous, that's different. That means that person is their healthcare proxy. And sometimes they make great choices, and sometimes they make not so great choices. But it's really having honest discussions about it. And the same thing I told you. Now, if somebody's sitting with me and their family member is giving them the blues, I look over and say, shh, 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 shh. Okay. And I did a case today. I'll give you a perfect example. The patient was very torn about what she wanted. She had loving friends who were very loving, encouraging her to have a surgery she really did not want to have. She had her mother on the flip side of that coin encouraging her the exact opposite of what her friends were encouraging her. And she was incredibly torn. And the bottom line we talked about is, what are you most comfortable with? Let's take all the noise out of the room. What is going to make you get your peace of mind back? Where are you going to find your sense of peace with this thing that has happened that you had no control over? And it is important to be able to understand your wishes. It is important. That's why I have Kathy and I have Markeisha and I have a staff to help do that hand-holding, because after you talk to me for 2 hours, what else you want me to say? Sometimes you need to talk to them a little bit. But it's having somebody to support you in your choices and respect your decisions. And I don't always agree with your decisions, but they're your decisions. And that I can respect and that I can follow along with.
Can dancing for the majority of your life have a negative impact on your joints in the long run? If so, how? And I'm going to add something. I don't know about everybody else, but like I have on 5-inch heels today. Love them, but maybe you could address that as well. But the question was about dancing.
Dancing. Okay, good. So low impact exercise is the best exercise for your joints. Anything in the pool, elliptical training, riding a bike, walking, running's a little higher impact. Dancing in particular, I know there's all kinds of forms of dancing, but if it's regular dancing, totally fine. Ballet dancers do put a lot of stress on their feet and their particularly the tendons in their toes, and some of those shoes are not very anatomically friendly. I'm talking about, ballet. I mean, there's no study on high heel shoes contributing to joint pain. They may make certain foot and ankle pathologies like bunions worse or more painful, but do what's important for you. Low impact exercise has actually improves joint health. The motion helps the joints lubricate themselves and maintain that cartilage. And so everybody asks, like I said, am I doing damage to my joint? Just keep it on the lower impact side. Certainly, we've got ex-athletes that heavy weightlifters, kind of people that are involved in very labor-intensive jobs are predisposed to arthritis. But there's studies in marathon runners showing that they really don't have a higher incidence of needing knee replacements compared to the general population. Obviously, they're all wire thin and in great shape, but runners, it seems to be okay, in moderation, so.
So is there something that you can do if you are an avid runner or dancer, either professionally or for fun? Is there something you can do to counter that if you're not always low impact?
Yeah, I will tell patients listen to their bodies. You know, at some point you kind of get an idea of what's normal, fatigue, a little bit of some aches and pains from maybe pushing it an extra mile or two. But when it's sore, when it's hurting you the next day after you've exercised, that may be a sign to, that is a sign to scale it back. You know, find another different activity to do. You know, it's great to keep our bodies guessing, right? You know, doing different types of exercise, reinvigorates different parts of our musculoskeletal system, and so, it's good to add that variety, and it also helps offload certain parts of your body that may be getting overstressed.
So here's another question. Mm-hmm. What causes horrendous lower leg cramps in bed at night? I take Pedialyte. It tends to help somewhat, but everybody's like, yeah.
Upper and lower? Is that what it says?
Yeah,
okay.
That's what it says. It's underlined.
Okay. So there's various etiologies to leg cramping. He says you've been taking the Pedialyte. The first thing we always think about are electrolytes, potassium, and sodium balance. When that is off, it can cause cramps to develop. There can be neurologic issues if there's nerves pinched in your back, can cause cramping in your legs. There's a specific condition called restless leg syndrome, believe it or not, where patients just have this inability to kind of keep their legs still and stay comfortable, and there are actually specific medications that can aim to treat that. So there are various etiologies. Obviously you started right with the Pedialyte and maintaining your hydration, making sure you're drinking plenty of water. If it's refractory to this, I'd probably recommend getting it checked out, some labs and maybe some imaging to see what could be going wrong.
So I've lost a lot of range of motion in my shoulder, but did not have an injury. What could that be? How do I fix it? It really hurts me, especially at night.
So women in particular are prone to what's called frozen shoulder or adhesive capsulitis. For whatever reason, even just a minor injury or even an overuse type activity can cause scar tissue to proliferate around the shoulder. Good news is it's almost always self-limited, meaning the motion almost always comes back, assuming that's the diagnosis. But it can take some time and some physical therapy. Cortisone shots can be very, very helpful, in particular for this condition. But it does kind of come out of the blue. We call it idiopathic, where maybe you were just doing normal activities around the house, and over the course of a few weeks, your shoulder just had some inflammation in it, and your body responds by forming additional scar tissue in the shoulder, and it does get better, but sometimes can take months, even up to a year or so, and then we can do a lot to get you feeling and moving better until it goes away.
My husband says it's that 2-ton purse you're carrying around all the time.
It's
causing all your shoulder problems. Maybe.
Purses and backpacks mainly put a lot of stress on the neck muscles. The shoulder itself is kind of when you're doing your abduction and activities out in front of you. So purses are fine.
I can tell him no.
As long as your neck's not bothering.
Good. Okay. What can we do? You addressed this much earlier. What can we do to increase or preserve fluid in the joints?
So yeah, there's physiologic amount of fluid. Usually it's sort of between 2 to 4 milliliters, and it does kind of diminish as we age, and the lubricating properties of the cartilage itself deteriorate over time. The analogy I use is kind of like the treads on the tire you get when you get your car. Unfortunately, we just use them and accumulate wear and tear on them, and it doesn't really regrow actually at all. Even with all sorts of stem cells and things, we don't have a great way to regrow completely normal cartilage into in our bodies. And so in order to keep things lubricated, low impact exercise, maintaining a healthy diet, and I can't underestimate or overestimate the importance of maintaining a healthy weight. And I know it's a hard thing to do. I have patients with bad joint pain, and I tell them to go lose weight and exercise. But there's ways to do it, and ways to work around it, and the more you can do, the better. So that kind of helps preserve our joints. She was asking about glucosamine, and I'll be honest, we have our society, American Academy of Orthopedic Surgeons, comes out with recommendations based on all the evidence that's out there, and they have recommended against using it. So I'll tell it's safe, and I'll tell patients if you take it and it makes you feel better, fine, but it's not cheap, and the glucosamine and chondroitin supplement for joint health.
So speaking of that, we're told to do weight-bearing exercises to maintain bone health. How do you find the balance of not putting too much stress on the joints, but maintaining strong bones as we age?
So, you know, I've mainly been talking about joint health, but then there's the whole world of bone health, and that's not specifically what I do. I deal with it when they're broken. You know, the biggest predictor of bone health going into, you know, later life is weight-bearing activity at a younger age. Kind of you build up those bones in your, you know, 20s, 30s, 40s, and you do your best to maintain them, you know, going on as we get older. You know, the balance, you know, weight-bearing exercise could be resistance training with, you know, an elastic band or a 5-pound dumbbell. You know, they don't expect, you know, 90-pound women to be lifting 400 pounds over their head. That's not what the goal is here, and I'm sure some of them can, and it's impressive, but I'm not being sexist, sorry. But maintaining, you know, just working to do some resistance training, even if it's just, you know, bands or dumbbells, you know, really does help maintain that bone health. And you know, that's, people are living longer and longer and longer, and unfortunately our bones aren't maintaining their health with us. And so, you know, we have a great rheumatologist group, you know, that we can work with patients to make sure, you know, if they need medications for osteoporosis, we can, you know, get them plugged into that system. And so, you know, you've heard probably a lot of the side effects about the anti-osteoporotic medications. We do know that overall they help prevent more fractures, you know, than there's what we call atypical femur fractures that can happen, and I'm starting to rant here, but they're much better at preventing your femoral neck fractures, your distal radius fractures, your compressive fractures in your spine, and your proximal humerus fractures that we do see in aging patients.
What is your view on the HPV vaccine for preteens?
I am absolutely wholeheartedly for it. And I was very happy when I found that now it's not just girls who can get it, it's boys. It doesn't make any sense if a girl may be having intercourse with a boy and she has a vaccine and he doesn't. There's no sense in that. The HPV vaccine now is instead of a quadrivalent, which means it covers against the 4 HPVs, now covers 9. But there's like 100 different types of HPV out there. So certainly the HPV vaccine, if you get it, it is not a license to go have unprotected sex, because you still can. All we're trying to do is to, again, mitigate risk. So we're trying to vaccinate against the most common HPVs that cause the most harm, but it also vaccinates against the low-risk HPVs that can cause genital warts, for example. And as of, I want to say, October of 2018, the age limits where we can get HPV vaccine increased. So it used to be before you had to be between age 9 and 26, but now you can be 45. So guess who went to get her HPV vaccine when I heard about that? So I have one more, and then I'm good. So I'm obviously less than 45 years old. But very important. My son has gotten his, so if I'm okay with my child getting his vaccine, I think you should be too.
Thank you. Ovarian cancer, if you have a family history, what's next? What should you do, if anything?
So unfortunately, there's no screening test for ovarian cancer. This is why it's very important that you should come to see your OBGYN or your family practitioner or internal medicine doctor every year. Some patients will come to me asking, well, my mom had ovarian cancer and my sister had it, so can you like do an ultrasound and check a CA-125 level every year? That is not the right answer to try to figure out what's going on. There are some genetic testing, and certainly Dr. Leonard can go into that as well. Depending on what your family history is, we may be able to do certain genetic testing like the BRCA test and other ones. And if you are at risk, then perhaps we may be doing a prophylactic oophorectomy, meaning removing the ovaries, sometimes moving the breast, depending on what you have and where you are in your lifespan. If you do come in and you're giving me some, very vague symptoms, I've had increased abdominal girth, I'm not eating, I'm not overeating, I'm exercising, and you're at, the 50 to 60 age range, you could have ovarian cancer. I call that the silent killer. And so depending on what you tell me, even though I'm not doing a pap smear every year, I listen carefully. And I might decide I'm going to order an ultrasound or a CT scan looking for ovarian cancer.
Okay, as a postmenopausal woman, having gone through this in the 40s, intimacy is no longer desirable to me. It's painful, I'm just not interested. Is this normal for a woman in the 40s?
I wouldn't say that it's normal, but it's common. So a lot of times your libido goes down, perhaps because you have painful intercourse. And so I use the analogy of, if I came to you with a hammer and try to like attack your knee, really try to hit you, would you come back to me? If I came back the next day with a hammer, what are you going to do? It's almost like you feel pain and you run away. Yeah. Then maybe you think about me and you're in pain. I didn't do anything to you. The same thing can occur with your libido. If you have, vaginal dryness for whatever reason, it could be from a chronic vaginal infection. It could be because you are getting into the postmenopausal range where your estrogen levels are now lower and you start having, pain. Why would you want to have sex if it hurts? That's just, that's a no-brainer for me. And then sometimes there could be some chemical imbalance. You could have, hypothyroidism or other, endocrinology disorders that could just make you have low libido. You could be depressed. You could have some interpersonal issues going on. And as crazy as it sounds, I talk about this with my patients all the time, maybe your husband didn't do the dishes one day. And you're like, oh yeah? Well. And then next thing you know, it's like 6 months later, and it was something so little as that 6 months ago, and it just keeps engendering over and over and over again, and then maybe you resent each other, and then you don't want to do it, then you're dry, and then you do it and it hurts, then you really don't want to do it, and then before you know it, you're 50, and then you don't use the vagina, you lose it, so then when you do, maybe things get better, he's doing the dishes, but everything is shriveled up a little bit, and then you try to have sex and it hurts, and then it's all over. So.
You asked, she answered. There we go. But with such a wide range of possible reasons.
Yes.
So now what happens when I walk into your office? Like, how do you figure that out with me?
Yeah. Also, you always ask me the question when you come for your one-woman exam, and 25 minutes have passed, and I have 3 minutes left. Yes. And I have to then sit down, and that's why it takes a long time to see Dr. Wexler, because I can't just let you go. But I kind of have to figure out like there are different causes. So, I try to get to know you a little bit, find out, are you sexually active? Does your husband have, sexual dysfunction or erectile dysfunction? Do you have any organic reasons why you should have, the decreased libido or, the pain? Do you have other medical problems that could be causing this, like a side effect of certain medications that we take? Certain antidepressants will decrease your libido as well. So it's not an easy question to answer, not an easy question to fix, but certainly I think I can fix it. It's partly here, but
also not always an easy question to ask, because you brought up a really good point, right? So don't come in and say, oh, I just need a pap smear, and then go, okay, so I don't want to have sex and have it like in 10 years. At the end, right?
So what I do, at least in my office, is I'll just make it very open-ended. Listen, you're in your 40s. A lot of patients come to me, and they tend to have this complaint. Do you have that issue? Just to kind of broach it and make it easier, because it is a hard thing to talk about. You don't know me from Adam. Why would you trust me with something so personal? And then the floodgates open.
Then we instantly trust you. Right. Okay. So what can you do? This is another question. What can you do for me? I want to go on a 10-mile hike, but I can't unless there's a bathroom nearby. What's the issue? What's going on? What can you do?
So you could, I have to figure out if what you have is what we call stress incontinence, where you jump, you sneeze, you cough, and you leak on yourself. Or is it urge incontinence, where your bladder gets full really quickly, and every 30 to 60 minutes you have that urge to urinate and you can't do anything. So if you have stress incontinence, that's something that we can fix surgically, but and I love operating, but before I go the surgical route, I try to get you to do different things. If you have a lot of weight, I don't care if you have a big booty, but any weight over here is going to be pressing on your bladder. So your intra-abdominal pressure, when it becomes higher than your intravesical, or the pressure inside your bladder, that pressure is going to make you leak. Just like pregnant women tend to leak because there's a big thing there. The same thing when you have weight on your belly. So losing weight is helpful. And of course the next question is, well, how am I going to lose weight if I leak every time I lose weight? You may have to wear a pad for a while. You may do exercises in the pool. Kegel exercises are very, well, it has chlorine, so I think you're okay. So Kegel exercises are very important for stress and actually for urge incontinence. I got frustrated with asking patients to, squeeze, pretend you're trying to hold your pee or your fart or your poop and squeeze, and half the time they're like doing this. So now I tell my patients to use what we call Kegel weights. They look like little balls and they have different sizes. You place it vaginally, so you have that kind of biofeedback where your brain knows that there's something cold in the vagina that you're trying to squeeze, as opposed to squeezing air. So doing those exercises are very helpful. And then, sometimes you may need to see a pelvic floor physical therapist to try to help with getting those muscles nice and strong. For urge incontinence, I treat that with medication. And then I do bladder training. So you have to basically train your brain not to think about urinating when you put your hand on the door or when you're about to, walk into your house. So, things like maybe before you exercise, empty your bladder, limit your water intake right before exercise, drink up afterwards, of course. Modify your behavior a bit so that you can do what you like to do.
Thank you. It seems like medical care is very siloed. You've got OB over here, and you got ortho, you got dermatology, you've got all these different disciplines. How can women find an integrative approach rather than dealing with multiple doctors who are sort of in their own lane? And then related to that, how do you address, from your perspectives, how do you address a patient with multiple health issues?
Well, a lot of the providers at MedStar Montgomery are actually trying to get together. We have, our M&Ms where we discuss common issues, or we have lectures actually every Thursday to be exact. And then for women's health, we do have a group of providers too who share a common interest in women's health to try to get to know each other so that if a patient has an issue, hey, I know, Dr. Macdonell, I know Dr. Leonard, let me call her. I have her cell phone number, I can text her at maybe not 2 a.m. in the morning, but I've texted pretty late to ask that question to try to help the patients. So we have a common electronic medical record. So if I send a patient to ortho, I don't have to wait for him to fax that report. I can see it right away. He can send me a note, really short note saying, hey, I saw your patient, is what I think, read my note. And so I think that is very helpful to us.
Anyone else want to weigh in on that?
I want to echo what Dr. Wexler said as well. There's a lot of now multidisciplinary tumor boards, which I think help people, all physicians from each specialty discuss either like a patient with melanoma, there's like the reconstructive surgeon there, surgical oncology, medical oncology, derm path, dermatology. We're all sitting in one room for an hour every week to talk about these patients. For breast cancer, we have tumor board, the radiation oncologist is there, medical oncology, the radiologist is there, Dr. Leonard's there, Kathy's there. So we can all talk about all the patients so that way they can get kind of everyone's on board. We can talk about their overall care. One of the clinics I do at Georgetown, there's a rheumatologist and a dermatologist in the physical clinic, and we see patients together. So I think that's sort of one of the blessings of MedStar branching out and stretching into the community is we're sending specialists there as well, so we can all sort of come together to see patients hopefully in one setting. That's sort of our goal with the Breast Health Center opening in the fall, is that Dawn and I can see patients together. So if you are diagnosed with breast cancer, there's any concern, we can see you in one setting versus coming back and forth and back and forth.
This is a different perspective. There's some importance to siloed care. Specialists specialize in what they do. Medicine has become so complex, and it's evolving every day, that we can't keep up with everything across every specialty. So even though it can be painful to have to see more than one doctor and that we can't go just to our primary care doctor anymore and they cover everything like the world of our old general practitioners, and our previous general practitioners and previous general surgeons, there is some benefit to having care in the hands of someone when that's all that they do. What the data shows is when you see specialists for special issues, you have better outcomes. You have access to clinical trials and cutting-edge treatments and therapies that you can't expect your family practitioner or your internal medicine doctor to keep up with. I have to keep up with the breast recommendations, which have changed every year. I couldn't imagine trying to keep up with the GYN recommendations, the GI recommendations for colonoscopy, what's good with joint health. I didn't even know anything about this stem cell stuff, so I've learned something today. Never heard of a Kegel ball, because that one was a big hit, and ain't nobody peeing in no pool. So that is not going to happen. But the reason why we have siloed care to a degree is so that you have access to people who are following their calling, because we are following our calling with passion, with love, with integrity, and with a desire to learn more, do more, give more to these patients. It provides you greater access. So the kind of icing on that cake is when we get to work in multidisciplinary settings, and when we get to sit down together, and we get to have opportunities to look at each other's notes, that's the icing. But the cake, the meat, is that doctor has spent all their time honing that craft to give you the best that is out there right now. So that's the benefit of siloed care.
Hold up. Don't go. Because I want to follow up on this a little bit, because I don't think this thought is in conflict with what you've said. I think it's a different perspective, which is, and I didn't see the back of the card when I initially read it. I think the concern here was about managing that siloed care from the patient perspective, because from the physician's perspective, for example, Dr. Sher, you talked about, so we get together periodically and we're talking about our similar patients, and I even heard some of that at the table today, right, before we ate, which is a good thing. From the physician's perspective, that's happening. But from what I think this is getting at is from the patient's perspective, the concept of managing that. So for example, I'm a patient, I go in to see Dr. Wexler, I have an issue, you order some tests, we're working with this issue, I have a different issue, I come to see you, and then you order some tests, and I'm the patient, I'm thinking, wait, did I do that test last week with Dr. Wexler? I think, is that the same one? Like, I'm not a doctor, so I can't remember. Wait, was it the echocardiogram or was it the electrocardiogram? Is that the same thing? So I think what they're trying to get at is, from the patient's perspective, managing all of that expert care that you may be getting it from. Does that make sense?
It does.
Okay.
So there's a twofold answer. One of the solutions to that, because that's complex across the country, not just here, is the concept of the patient navigator. Navigators who work with us, who are typically nurses or social workers, and they have different specialties to help patients navigate those things. So that's one aspect that can be helpful, and there are a lot of navigators in the system. We have one for breast, there are some for ortho, there may be some for oncology, but that is their job, to help you navigate the system and to help put these pieces together. The flip side of that coin is be honest. Tell us who you see and why. Because if we don't know who you see and why, we can't send them the documentation so they know what we're doing. The old adage that I tell my patients is, we know y'all lie. We know. You don't always tell us everything. People come see me for breast and they don't tell us everything because they think it's not related. Well, that has nothing to do with my breast, so I'm not going to say anything about those 6 people who had ovarian cancer and colon cancer in my family. So just be open and honest with the provider so that they have the opportunity to start putting those pieces together for you. If you say, you know what, I don't know if I had that test, well, it's a lot easier for us to go see if we can hunt it down than for you to figure it out. And one of the things Dr. Wexler said I think is really important, and that Ms. Potts said that's important, is, it's hard to ask these questions. It should never be hard to ask a question. If you're afraid to talk to your provider, get another provider. You should be able to have an open and honest conversation. And if you can't, that there's something that we're not providing, or that might not be the right relationship for you. But there really should, because we're in medicine, we may have little things we chuckle about in our brain, but the bottom line is that we're there to care for you. And if there are things about your health that you feel uncomfortable, that we're not going to be receptive to, you need another provider. Because we can't fix what we don't know. And we can't fix what we refuse to hear or refuse to see.
Thank you.
When you do have multiple medical problems, don't just, yes, we think siloed care is important. It's very important that you involve your primary care doctor.
Always.
So you have to tell, that person can be that, that gatekeeper who knows that Dr. Leonard ordered it. I might not know that the medicine I gave you could, have some kind of bad interaction with what she gave you. Or maybe she doesn't know either, and your primary care doctor knows you have hypertension, for example. So making sure that you also take some control of your care and letting at least somebody who's knowledgeable, like your primary care, your internist or your family practitioner, know that you're seeing a gynecologist and an orthopedic surgeon and a breast surgeon and a dermatologist. So that person knows, oh, let me just make sure that I have those doctors' notes, and then I can, use my brain power to figure out if there's some contraindication to maybe you have depression or something else, and that medicine could be causing some side effects that could be causing ill to something else. So I love for you to see me, but I'm not a primary care doctor. See your primary care doctor as well, because that person could save you from something such that you think is not important, that I may not think is important, but they see the big picture. We sometimes are in our own lanes, so seeing someone who can see the big picture, still see us, I think will help you.
I have perineal brevis tendinitis. How long does it take for that to heal?
Perineal brevis tendinitis can take several months to get better. I usually, depending on the severity, will put patients, and for severe cases, I'll give them a cam walker boot just to so for those who don't know, perineal brevis tendon is a tendon down on the outside of your foot that helps you kind of move your foot in and out and accommodate uneven ground. But it can take a few months to get better. If it's very severe, I'll often put patients in sort of a cam walker boot to calm everything down and then get them into some physical therapy. But it does, studies show kind of between 5 to 8 months to really get, markedly improved.
Thank you. How many cases of rheumatoid arthritis do you see, say, in a year, and how do you typically go about treating it?
I don't medically manage the rheumatoid arthritis. We have seen a drastic decrease in the amount of rheumatoid arthritis patients needing joint replacements because of what we call the disease-modifying anti-rheumatic drugs. The commercials you see for Enbrel and those types of medications really have gone a long way to modulate the pro-inflammatory state that comes with rheumatoid arthritis. So I certainly have done my share of surgeries on these patients, and we do injections and things for them to modify and make their symptoms more manageable. So on a typical day when I see 25 to 30 patients, 3 or 4 of them usually have some rheumatologic condition that I'm helping to treat. But the mainstay of treatment for those conditions has been the medical management, which has really made significant improvements in their need for surgery and their conditions.
I'm not sure if this is up your alley, but
Okay.
if it's not, point us in the right direction. Ugly veins are an issue.
Mm-hmm.
Are the risks of vein surgery and treatment worth the results? What are the risks? How long do the results last?
Yeah, not my wheelhouse. I will tell you preventatively, using your compressive stockings and maintaining so that people develop veins, with normal aging, as well as losing the elasticity in the walls of the veins cause spider veins and varicose veins. And so utilizing compressive stockings, maintaining the muscle strength of your lower extremities helps prevent them. Don't have great answers, and I don't want to lead any misinformation on the vein surgery, so I'm gonna duck that one.
Okay. Well, since you ducked, I'm going to put it in my follow-up questions.
Okay.
How's that?
Perfect.
Can I have a knee replacement if I'm slowly recovering from severe sciatica? And let me just add to broaden that out a little bit.
Mm-hmm.
Are there any other conditions that might prevent you from having
Right. So knee
surgery?
replacement, hip replacement, any elective surgery is a risk-benefit analysis. And everybody asks, when's the right time to have a knee replacement? When's the right time to have a hip replacement? And I can't answer that for you, individually. This arthritis slows you down, it hurts you, it makes life miserable, but it will not kill you. Okay. So the question is, one, when this pain from this arthritis is having a significant impact on your function and quality of life, that you're saying, hey, I got to do something about this. You understand the risks and benefits, which I'm always happy to explain to people, at length and answer any questions about. As far as the contraindications to surgery, as the main thing we worry about in hip and knee replacement surgery is infection. The infection rate is around 1%. That's not a high number unless you're in that 1%, because it can be pretty severe when it does happen. And so things that can predispose you to infection, poorly controlled blood glucose, really high BMIs, any open wounds or infections ongoing in your body that could predispose you to having, infections in the joint replacement. And, there's other medical factors that can contribute to them. But basically, we take the picture of everything in that patient as a whole. And people ask, am I too old for a joint replacement? And I'll say, sort of, age is just a number. I've had 91-year-olds that I've done elective hip replacements on that are healthier than some of the 55-year-olds I've done them on. And so, we kind of take that, as a global picture with help of the primary care providers, because I won't do the surgery without them saying you're healthy enough for it. Recovering from, an exacerbation of your sciatica isn't necessarily a contraindication to having the surgery. If you were taking corticosteroids for that, I would probably want you to be off that for a few weeks so it didn't impact any wound healing. But, just like with most, medical decisions and obviously surgical decisions, it's an individual decision based on your risk factors and, so.
So, as usual, I'm sure there's some questions that were not answered. We still have a stack. So, we listened to you last time we were here, and we videotaped the talk. So, we will be able to share some of this on social media and on our webpage. And this will give us an opportunity to also have other people ask some questions, and we can probably get those answered at a later time. So thank you for that great feedback, and thank all of you for being here this evening. And we look forward to seeing you next year, hopefully same time, same place, for the next Girl Talk with the Docs. Have a good evening.
Very good.